Welcome to the Language Clinic channel. Now we are going to talk about on smoking cessation, total 12 questions and the answer to the 12 questions. Our topic is now smoking cessation. In this lesson we will learn about the bad effects of smoking, about the effects of smoking on cardiovascular health. Especially, we will try to focus on the relation between smoking cessation and the cardiovascular health. So let's start by asking a question. Question number 1. Why is smoking cessation of fundamental importance in the management of cardiac patient? Answer is smoking cessation is the most important of the modifiable risk factors for cardiovascular disease. The products of tobacco smoke contribute directly and distinctly to the development of atherosclerosis and adverse consequences that follow. The benefits of smoking cessation cannot be exaggerated. A rapid and sustained reduction in the likelihood of cardiac disease or a cardiac event occurs in those who successfully stop smoking. Those with established cardiac disease experience a dramatic reduction in the likelihood of recurrence, complication, or death following cessation. In both instances, the benefits of smoking cessation accrue rapidly and reflect the elimination rather than the ongoing management of a major risk factor. Smoking cessation should be accorded a priority in those with cardiac disease. If in every professional setting, to do otherwise can be seen as reflective of substandard care. Now let's talk about smoking and the genesis of cardiovascular disease and cardiac events. The products of tobacco smoke, number 1, contribute to a pro-inflammatory state. Number 2, damage endothelial surfaces. Number 3, induce endothelial dysfunction. Number 4, distort the lipid profile and oxidize lipoproteins. Number 5, facilitate platelet aggregation and activation. Number 6, elevate fibrinogen levels. Number 7, potentiate the development of atheroma. Number 8, contribute to plaque instability. Number 9, produce elevated levels of carboxyhemoglobin and impair oxygen transport. Now let's talk about the mortality risk reduction in those with coronary heart disease. Smoking cessation 36%, statin therapy 29%, beta blocker therapy 23%, ACEI in eye therapy 23%, and ASA therapy 15%. ACEI means angiotensin converting enzyme I. ASA means aspirin. Mortality risk reduction associated with smoking cessation in patients with coronary heart disease. And the source is Journal of the American Medical Association. Now let's go to question number 2. Why have cardiologists neglected the treatment of tobacco addiction in the past? The answer is, for too long, a variety of dogmas and misconceptions have surrounded the management of the patient who smokes. Prominent among these were the perception that smoking was a habit or a lifestyle choice and that successful smoking cessation required little more than grit and determination. These outdated beliefs have impeded our ability to address this fundamental major cardiovascular risk factor. Assumptions and misconceptions have also clouded clinicians' understanding of the role that pharmacotherapy can play in aiding cessation. Misplaced concerns regarding the safety of nicotine replacement therapy or NRT in the cardiac setting for example, have sometimes precluded the use of this effective cessation pharmacotherapy. Question 3. What should every healthcare professional know about smoking? The answer is nicotine is the most addictive substance encountered in one's community. It takes only a few days to establish nicotine addiction once inhalation has been mastered. Thereafter, brain function, structure, and neurochemistry become transformed. Smokers smoke to ensure constant levels of nicotine and the elevated levels of dopamine and other neurotransmitters, whose release follows the stimulation of nicotine receptors. The cigarette is a perversely engineered drug delivery device constructed to deliver a precise aliquot of nicotine as rapidly as possible. Following the inhalation of tobacco smoke, nicotine is delivered very rapidly via the arterial system to the brain stem, where it initiates a cascade of neurotransmitter activity and dopamine release. Most smokers know why they should not smoke. Most smokers know why they should not smoke. Most smokers do not want to be smokers, and many smokers will make one or two unassisted quit attempts each year, most of which will fail. Smokers generally do not need more education or lectures. They want help. Optimal cessation strategies involve the following. Number 1, provision of pharmacotherapy to eliminate or curb the symptoms of withdrawal and craving that lead to the use of a cigarette. Number 2, communication of strategy. Communication of strategic, tactical advice regarding the management of those circumstances, settings, and situations that typically accompany and stimulate smoking. Number 4, how might smokers with cardiac disease be better assisted with cessation? The answer is a systemic approach to the identification and documentation of the smoking status of all patients in every clinical setting permits the provision of advice regarding the fundamental importance of cessation in the management of any cardiac condition. More importantly, it prompts the delivery of specific cessation assistance and appropriate follow-up. Serendipitous considerations of smoking status, offhand advice regarding the need for cessation, or the assumption that this is the responsibility of others, typically the family physician, have contributed in the past to substandard care of the cardiac patient who smokes. The management of tobacco addiction can be addressed in exactly the same way as other cardiovascular risk factors. A risk factor is identified, a strategy for its management is outlined, and medication is provided, monitored, and titrated for as long as is necessary until a desired endpoint is reached. Contemporary approaches to smoking cessation reflect exactly the same approach. They involve the provision of tactical advice and counseling in association with the use of appropriately prescribed and often titrated cessation pharmacotherapy. This is provided until a patient, free of the discomfort of cravings and withdrawal symptoms, acquires a repertoire of non-smoking behaviors and is able to comfortably tolerate all the circumstances and situations that were previously associated with smoking. In hospitals and other settings, clinical protocols, care maps, and other systematized approaches to the identification and treatment of smokers are becoming the norm and greatly facilitate and enhance the care of patients addicted to tobacco. Now, let's talk about a graph. A systemic approach to smoking cessation in every cardiac setting. First, identity. Identify the smoking status of all patients. Have you used any form of tobacco in the past 6 months? Have you used any form of tobacco in the past 7 days? Next, document is ensure that smoking status and history is documented in the medical record and prompts an appropriate cessation intervention. Third step, advise. Ensure that the patient is advised of the importance of cessation in an unambiguous, non-judgmental, personally relevant manner. Fourth stage is act. Provide cessation pharmacotherapy and strategic cessation advice as appropriate. And the last stage of systemic approach to smoking cessation in every cardiac setting is follow-up. Arrange appropriate follow-up, smoking cessation clinic, primary care practitioner, community services, quit lines, etc. So this is the strategy which we can follow to quit smoking. Okay, now let's go back to question number 5. What is a good starting point of smoking cessation? The answer is, in the past, approaches to smoking cessation have placed an emphasis on patient preparation and planning prior to reaching a quit date. There is increasing evidence that asking about willingness to embark on a quit attempt at the time of a patient encounter can be very helpful, capitalizing on any recent clinical event and a patient's interest in cessation. Even among those disinclined to make a quit attempt, the provision of a smoking cessation pharmacotherapy, which will induce a decline in cigarette consumption, has been demonstrated to be effective in stimulating a quit attempt and cessation. This approach mirrors our initial prescription of lipid-lowering or antihypertensive medications. Their effectiveness is evaluated in the weeks that follow, when retitration of therapy may be necessary. This reduce to quit or RTQ paradigm may be particularly appropriate in the cardiac setting, where further follow-up is likely to occur. Both the patient and clinician will be pleasantly surprised to note that cigarette consumption has fallen appreciably. This serves as an appropriate entry to a more carefully planned cessation attempt with a specific focus on titration of pharmacotherapy and ongoing follow-up, perhaps in association with the family physician. Question 6. How can one best use pharmacotherapy to optimize the likelihood of cessation? The answer is the appropriate use of pharmacotherapy, its monitoring and titration, and follow-up will substantially increase the likelihood of successful cessation. 3 generations of pharmacotherapy are currently available: NRT, bupropion, and varenicline. Patient experience or preference may be the fundamental determinant of choice of therapy. Combination of NRT, PAS plus short-acting NRT, and varenicline have demonstrated the greatest overall effectiveness, tripling the likelihood of successful cessation. In all cases, the titration of therapy may be necessary to ensure effectiveness or to mitigate certain side effects. Question 7. Can NRT be initiated in the inpatient setting for patients with cardiac disease? The answer is a big yes. NRT may be offered to smokers with hours of patient admission. Nicotine withdrawal will occur rapidly in many smokers, producing discomfort, a variety of behavioral challenges for clinical staff, and complicating compliance with the treatment of their cardiac condition. Evidence has been accumulating for years attesting to the safety of NRT in cardiac patients. Nicotine in this setting is delivered slowly via the venous system, not the arterial system, as is the case with smoking. Achieves steady state levels that will always be far less than those to which a smoker has been accustomed. Is not accompanied by carbon monoxide and countless other toxins. and is being provided to patients who have developed marked tolerance to the cardiovascular effects of nicotine. Standardized order template may be useful. Now let's talk about a table. University of Ottawa Heart Institute standard orders for NRT, bupropion and varenicline. Standard orders for NRT: 20 cigarettes per day, 21 mg NRT plus or minus short acting NRT. 30 cigarettes per day, 21 plus 7 mg NRT passes plus or minus short acting NRT. 40 cigarettes per day, 2 into 21 mg NRT passes plus or minus short acting NRT. Standard orders for bupropion: days 1 to 3, 150 mg QD means thrice a day, and day 4 to week 12, 150 mg bead means twice a day. Standard orders for varenicline: days 1 to 3, 0.5 mg thrice a day or QD. Days 4 to 7, 0.5 mg bead, that means twice a day. Weeks 2 to 12, 0.5 to 1 mg bead, that means twice a day. Initial course may be repeated. In each case, be prepared to titrate therapy to ensure control of withdrawal and craving or to address dose-related side effects. Therapy may be prolonged as is necessary in order to prevent relapse to smoking. Consideration may be given to combining therapies in those in whom single-agent treatment is insufficient to address symptoms of withdrawal and craving or in whom total cessation has not been achieved. Short-acting NRT is an NRT inhaler, NRT lozenge, NRT spray, or NRT gum. NRT means nicotine replacement therapy. Okay, now let's talk about question number 8. What if a smoker reports that NRT has not decreased their desire to smoke? The answer is many smokers will report that the use of NRT is not associated with any decrease in the desire to smoke, a classic indication of underdosing. It has been calculated that the standard doses of NRT, for example, will not meet the nicotine needs of a majority of current smokers. Smokers are able to titrate nicotine intake with considerable precision. Thus, the use of a nicotine inhaler in association with a nicotine patch will allow the emerging non-smoker to titrate nicotine to meet particular needs, usually at times of more intense cravings or withdrawal. Use of NRT, as with every cessation pharmacotherapy, can be continued until its discontinuation is not accompanied by an urge to smoke or a lapse to smoking in response to certain stimuli or surroundings. It is exceptionally rare for patients to become NRT dependent. Question 9. Can bupropion be useful for smoking cessation? Answer is, as an antidepressant, bupropion was found to be efficacious in smoking cessation. It stimulates noradrenergic and dopaminergic centers in the brain associated with withdrawal and craving, respectively, and may also act as a nicotine antagonist. It is contraindicated in those with a history of or propensity for seizures, that means convulsions. Like all smoking cessation medications, it may cause transient insomnia or sleep disturbance and can be associated with dose-related side effects like dry mouth, skin rash, tremor, among others, that will respond to titration of therapy. In this case, a reduction in dose, its use begins with a 7-day period during which doses are gradually increased to achieve therapeutic levels prior to a quit date. Question 10. Can varenicline be useful for smoking cessation? The answer is varenicline acts as an alpha 4 beta 2 nicotine acetylcholine receptor partial agonist and partial antagonist. As such, it stimulates this receptor, triggering a degree of dopamine release in the forebrain while occupying and blocking the receptor site, thus preventing nicotine from exerting any effect if smoking occurs. Most patients receiving varenicline experience little or no craving for nicotine, and if a cigarette is smoked, derives no sensation or benefit typically associated with smoking. It has been shown to be the most effective single agent in inducing cessation and has demonstrated effectiveness in those with stable cardiovascular disease. Concerns have been raised about an increase in cardiovascular events among those using this medication. However, no clear evidence of a causal relationship has been identified, nor has a biologically plausible reason for any such effects been identified. The publication of a recent meta-analysis has dispelled those concerns. The risks of any smoking cessation pharmacotherapy must always be considered against the risks of continued smoking. The principal side effect of varenicline is nausea, which can typically be managed by taking the medication with meals and a full glass of water, or by reducing the dose. Question 11. What are other potential therapies for smoking cessation? The answer is cetacine, a naturally occurring alkaloid derived from the leaves of a shrub, acts like varenicline as a partial agonist of the alpha 4 beta 2 nicotine acetylcholine receptor. Despite being used as a cessation aid in Eastern Europe for decades, there are few studies evaluating its use. Recent evidence shows that cetacine is effective in smoking cessation when compared to placebo and NRT. However, additional large, high-quality randomized controlled trials with longer follow-up would strengthen the certainty of this evidence. Side effects are self-limiting and include nausea, dyspepsia, and sleep disturbances, all as a consequence of nicotine receptor stimulation. Contraindications to cetacine include hypertension, advanced atherosclerosis, and pregnancy or breastfeeding, though the comparator should always be continued smoking. The complex dosing regimen is seen by some as a barrier to its use. Cetacine can be produced cheaply, and its price and a more straightforward dosing strategy would suggest an important role in a process to cessation in the future. There is only very weak evidence to support the use of nortriptyline, a tricyclic antidepressant, as an aid to smoking cessation. It is not commonly used in smoking cessation practice. Now let's talk about the table. Cetacine dosing regimen: days 1 to 3, frequency while awake, 1 tablet 1.5 mg quarterly, 2 hours, every 2 hours. Maximum daily dose 6 tablets, days 4 to 12, 1 tablet 5 hour every 5 hour, 3 times, Q2. Maximum daily dose 5 tablets. Days 13 to 16, 1 tablet 3 hourly. Maximum daily dose 4 tablets. So days 17 to 20, 1 tablet 5 hourly. Maximum daily dose 3 tablets. Days 21 to 25, 1 tablet every 6 hours. Maximum daily dose 2 tablets. Okay. Now let's talk about our last question, and the last question on smoking cessation and the cardiac health is: what is our current understanding of the use of electronic nicotine delivery systems for smoking cessations? The answer is electronic nicotine delivery systems, or ENDS or ENDS, are often referred to as e-cigarettes or vapes. Their design and underlying technology have evolved considerably since their introduction. ENDS or ENDS are electronic nicotine delivery systems, heat a solution containing nicotine and typically an array of complex flavoring agents to produce a vapor that is then inhaled. More recent devices, as for example Juul puff bars, use nicotine salts to deliver levels of nicotine not possible with a conventional cigarette. It is argued that the inhalation of nicotine containing vapor is less harmful than the inhalation of nicotine containing smoke, which is correct from an oncologic perspective. Oncologic means cancer perspective. It is increasingly recognized, however, that many of the products contained in the vapor produce respiratory tract damage. There is increasing evidence that they also stimulate inflammatory changes in endothelial surfaces, impair vascular function, and promote atherogenesis, producing responses typical of those that foreshadow atherosclerosis. An epidemic of nicotine addiction has been unleashed among youth and young adults, many of whom are non-smokers, by the widespread availability and aggressive marketing of these products. There is limited evidence demonstrating that in clinical trials, nicotine containing ENDS or electronic nicotine delivery systems are an effective cessation aid compared to placebo or NRT. Studies of smoking cessation in the population at large demonstrate that cessation is not enhanced by the use of ENDS or electronic nicotine delivery systems, that most ENDS users continue to smoke while using the devices, becoming dual users, and that the likelihood of cessation is reduced. Non-smokers who use ENDS are more likely to become smokers than those who do not. It has been calculated that for every smoker who achieves cessation, 80 teenagers become addicted to nicotine. The need for their appropriate regulation, nicotine content, flavoring agents, marketing, taxation has been recognized in many jurisdictions. Healthcare providers should strongly advise against the recreational use of ENDS or electronic nicotine delivery systems. Smokers may decide to use ENDS as a second line cessation aid. They should be encouraged to discontinue all cigarette while using the device, and thereafter to set a quit date for ENDS use. Clinicians can anticipate requests for cessation assistance from ENDS users who wish to discontinue the use of these devices. Additional high quality long term research is necessary in association with appropriate product regulation and standardization before ENDS can be considered first line pharmacotherapy for smoking cessation. To date, no manufacturer of ENDS has applied for permission to market their devices as a smoking cessation aid. So that's all we talked about smoking cessation and the relation of smoking cessation to cardiovascular health. The bottom line is, the sooner you quit smoking, the sooner you have a good cardiovascular health. So I hope you did enjoy listening to this lecture or video, and you enjoyed yourself while watching this, and I hope we all will stop smoking, because stopping smoking, quitting smoking helps us to regenerate our cardiovascular damage or cardiovascular disorders. So thank you very much for watching this, and wishing you all a good cardiac health.